Welcome to another episode of the MEGIN Spotlight series. Today we are delighted to have Dr. Arjan Hillebrand as our guest. He's an associate professor at the Clinical Neurophysiology department at Amsterdam University Medical Center. Hi, Dr. Hillebrand. Thank you for joining us today.
Hello, thank you.
VUmc is rated as one of the best academic medical centers in the country in terms of patient care and research. Besides the established use of MEG in patients with epilepsy who are candidates for epilepsy surgery, MEG is also routinely utilized for differential diagnosis in patients who visit VUmc's memory clinic. So, particularly in your area of expertise, can you please tell our listeners more about your main areas of research and clinical interest?
Of course I can. So maybe for those of you who don't know our center, so we're based in Amsterdam. The MEG system is based in the fully integrated in the Clinical Neurophysiology department, which is part of the neurology department. And there are a couple of focus areas in the neurology department. So that's different neurological disorders such as dementia, MS, movement disorders, and then brain tumor patients and patients with epilepsy. And the MEG system is used both clinically and to look at these different disorders. And the research is aligned with the focus areas of the neurology department. Those are the main focus points for the MEG, use of MEG. We also have external collaborations to look at other disorders, for example, look at patients with schizophrenia, also look at healthy subjects, so more like a neuroscientific approach. And then we have new collaborations together with colleagues in the AMC in Amsterdam to look at disorders of consciousness, where the idea is to use MEG to get an objective measure of the state of consciousness, and also to get a prognostic markers. With MEG, we look at different levels at brain activity. So first of all, we look at the local activity. So maybe to start, we almost always go back from the sensor level recordings to the source level, so to reconstruct the activity at the brain level. And then we look at three different levels at that activity. So locally, so you can look at the changes in the natural brain rhythms that occur, or for example, you can look at the excitation inhibition balance for different regions. Once we have the activity for the different regions, we can also look at the interactions between regions, so how different brain regions interact with each other. And once you have these interactions, you can look at the functional networks that are formed by these interacting brain regions. And of course, in disorders, you can then examine how these networks disintegrate. So there's three different research focuses. So first of all, we want to see, we want to find out different mechanisms or the mechanisms underlying these disorders. We're looking at non-invasive biomarkers. An example of that is in dementia, where we want to be able to have a differential diagnosis for different types of dementia, so Alzheimer or other types of dementia. And we try to develop novel methodology for our clinical work in epilepsy patients. So can we reconstruct the focus of the epileptiform activity more accurately? And can we predict which areas should be resected in order for the patients to become seizure-free? And on top of that, we try to link our MEG findings or explain our MEG findings with computational modeling. So the computational models can be used to study or to come up with mechanisms that can explain our MEG findings.
We hear you're doing some work with epilepsy computational modeling, which sounds very interesting. Are you able to tell us more about this?
Yeah, I think it's a nice example of how we integrate our MEG data with computational models. So we've done work using MEG to reconstruct the functional networks in patients with epilepsy, with the idea that these functional networks or the properties of these networks can tell you something about where the origin of the problem lies in these patients. And there you could think, for example, of central areas, so-called hub areas in the network that might be related to the focus of the epilepsy. And indeed, we found, this is in prospective data, so these patients had an MEG recording and were subsequently operated upon. So we know what the outcome is for these patients, and we found that the properties of the MEG networks were actually linked to could be linked to the resection area. So, in other words, MEG could tell you what the surgeon did or should do. The only problem or not so good result of those studies is that it didn't relate to the surgical outcome. So there was an overlap between the MEG results and the resection area in patients who became seizure-free afterwards. But there was also an overlap for patients who were not seizure-free. So clearly something was still missing in those patients. And well, we think the problem is that we took a very sort of static snapshot of the state of the systems of the functional network. So we've now used or started to use computational modeling to get a more dynamic idea. So here we use computational models to get a model of the spreading of activity, seizure activity over the functional brain network. And the good thing is, well, we can use MEG data to inform those computational models. And the good thing is, once you have such a model, then you can start kind of play with it. So you can do what we call virtual resection. So you can perform an action on this simulated network for the individual patient. And then you can look what happens to the spreading of this seizure activity. So if the surgeon has a certain plan of attack, if you like, we can test that in the model, and we can hopefully inform the surgeon that it's a good idea to perform that surgery, that strategy, or maybe we can test out different alternative strategies. So this is work that's been well ongoing for about 2 years, and we're making progress with it. And if you're interested, we actually have just developed a website called www.virtualsurgeon.net, where we show our initial results, and there's also a very nice animation that explains what we're trying to do in a probably much better way than I just did.
So hearing now how MEG is being used in your research projects, my next question leads into why did you select MEG as a neuroimaging modality across a wide range of patient populations and neurological conditions? What aspects of MEG stand out as a benefit to you?
Yeah, the main benefit really is, well, if you look at how we look at different disorders, you can look at all or many different disorders from a network perspective. So in many disorders, there's a disintegration of the network. Even in for example, epilepsy, the traditional view is that there's a focal problem in many types of epilepsy. But even in those cases, the epilepsy can also be seen as a network disorder where the spreading of epileptiform activity over the network gives you useful information of what the focus is, and also can help you to understand how seizure activity originates or starts. So if you take this network perspective, then you need a tool that can reconstruct the whole network, and preferably in a non-invasive way. So that's where modern MEG systems come into play. You get a snapshot of activity with a high temporal resolution from the brain as a whole, so you can reconstruct whole brain networks. So that's the main reason you get high or reasonable spatial resolution from the whole brain. But of course, you still have the main benefit of MEG, which is the high temporal resolution. So once you have reconstructed the activity locally for many regions, or once you have reconstructed the functional brain networks, you can look at that activity in detail with high temporal resolution. So you can look at, for example, different brain rhythms. You need a high temporal resolution if you want to look at functional connectivity. So if you want to look at functional interactions between brain rhythms. Also, if you want to see how the functional networks evolve over time, of course, you need the high temporal resolution. Because this combination of high temporal resolution with whole brain sampling with a good spatial resolution. That's why we use MEG.
The research aspect of the center is clearly groundbreaking and presumably essential in many ways to pave the way for MEG to be used clinically. Can you tell us how VUmc is using MEG in clinical applications?
So there's two main clinical applications in our center. So first of all, there's the epilepsy work. So we see about 100 patients with epilepsy every year as part of their pre-surgical evaluation. So MEG is used there to gain more information about the focus of the epilepsy and whether there's a high chance of success when the patient is operated. And the way this is set up is the recordings are always done by EEG, MEG technicians. Typically, we record about 4 recordings of 15 minutes in order to have a high chance of recording epileptiform activity. We also record healthy responses, responses due to movement or sensory stimulation. And we do that so that we can localize eloquent cortex. That's also useful information for a surgeon to know which parts of the brain are still healthy. So the patients do those, the technicians perform those recordings. They also analyze the data. Maybe I'll say a little bit more about the kinds of analysis that they do. But they analyze the data and they produce a report, which is then discussed in a meeting where, of course, the technicians are present, also clinical neurophysiologists and physicists. And the analysis and findings are discussed. Perhaps there might be suggestions for further analyses. And then ultimately, a clinical report is created, which is then used by the surgeons in combination with other results from other techniques and clinical information for the surgical planning. And if the all the different kinds of clinical information don't align, then the MEG data might also be used in the planning for invasive recordings with invasive EEG, so depth EEG recordings. And the kind of analysis that the technicians do is, the traditional analysis is dipole fitting. So the technicians, they look for spikes, epileptiform activity, and then try to localize the source underlying that activity using dipole fitting. And a novel approach that we use is we make use of virtual electrodes. So virtual electrodes are a reconstruction of brain activity using a beamforming approach. What you get is an estimate of the time series of activity, including the epileptiform activity. And these time series are almost as if you record from a region with a depth electrodes. And in fact, we've done a comparison of these reconstructed virtual electrodes with depth electrode recordings. And we found that the information is very similar in these recordings, even though the recordings were several months apart. So you get a quite faithful reconstruction of activity from different regions in the brain. And the way we use these virtual electrodes is to either test hypotheses or generate new hypotheses. So for example, if there's a strong suspicion that there might be a hippocampal source, these deep sources produce small spikes at the sensor level that may be even missed on visual inspection. So you wouldn't be able to localize those sources using dipole fitting, but then if there's a strong suspicion, you could place a virtual electrode in the hippocampus, reconstruct the activity, and what we often find is that you can then clearly discern these epileptic form disturbances in these virtual electrodes.
So it sounds.
So that's the epilepsy case. And of course, many centers are also looking for novel clinical applications of MEG. And I think we're one of the first centers in the world to take MEG to the clinic, to our dementia clinic. So the MEG department is actually around the corner of the memory clinic here. And well, for many years now, EEG has been used by the memory clinic. So early in the week, an EEG is taken, and the sort of the information from the EEG is then used together with other information from other modalities, so from MRI, maybe PET, or CSF. And then all that information is used together in a consensus meeting to go at the end of the week to come to a diagnosis, a differential diagnosis. And what we've done a couple of years ago is we've started to replace some of these EEGs by MEGs. So these MEGs are done, MEG recordings are done early in the week. In the same week, a clinical report is created again by the technicians. Then they do the analysis, and then the clinical neurophysiologist creates the report. And that report is then brought into this consensus meeting at the end of the week. And we've done that for a couple of years now. The workflow has just been described and published. And we also have a new manuscript on the review, hopefully will be published soon, where we describe how we use this approach to come to a differential diagnosis. So we use machine learning to get a probability of, or a likelihood that a particular individual patient has a certain type of dementia. And I think this is really pushing MEG sort of into the clinic in new ways.
So it sounds like that MEG is sort of utilized as a standard, which is fantastic. We hope to see this type of progress amongst many institutions globally, really. So looking at the center overall, how is MEG incorporated into the operational flow of the neurology department on the clinical side? In other words, is MEG used in conjunction with other modalities, and if so, which ones? You've touched on some of that already, but let's find out a bit more.
Yeah, I think for the epilepsy, of course, MEG is used with other modalities. Often these patients, or almost always these patients, have already had an EEG, or maybe a long-term EEG, so video monitoring. There's also clinical information about the type of seizures that they have, and all that information is put together and used by the surgeons to come up with a surgical plan, or if necessary, for the planning of invasive recordings with that EEG. And like I said, for the memory clinic, the analysis is again done by the technicians, and then the clinical neurophysiologist creates a report which is used in combination, again with information from other modalities like MRI and PET to come to a consensus diagnosis.
So we're always interested in hearing about how MEG supports institutions on an individual basis. Is there a particular case that you can elaborate on in which MEG has made a difference to the patient outcome?
Yeah, there's probably many cases. One that comes to mind, because it's quite a recent case, is where MEG recording was done. It's a case of a patient with epilepsy, and the spikes were quite small, but we were still able to localize the focus, although not with a high confidence, and also the clinical information was pointing in different directions. So this patient wasn't ready to undergo surgery. So that's why depth EEG, so invasive EEG recordings were performed. And well, the electrodes, or one of the electrodes was placed through the MEG focus. And turns out that the clinical, sort of the seizures started within this MEG focus. And based on the clinical information, the surgeon wouldn't have put any electrodes in that region. So without MEG, this invasive, very stressful EEG recording would have resulted in non-conclusive results. So MEG really helped here to gain valuable clinical information.
Thank you, Dr. Hillebrand, for your time today. This has been a very insightful discussion on how you're utilizing MEG at VUmc in Amsterdam. And thanks again for taking the time today.